Hi, my name is Brandon Foreman. I'm at the University of Cincinnati, and I'm going to talk to you about some data we've been putting together in this poster entitled Brain Tissue Thermal Conductivity Regional Quantitative Brain Edema Values After Severe Traumatic Brain Injury. We know that cerebral edema is a determinant of outcome after severe injuries, but this has to be inferred through our clinical exam or through imaging. The thermal conductivity of a substance can be calculated through the diffusion of heat. That means you can calculate water content in any substance, including the brain. The FDA-approved intracranial dual thermistor QFlow 500 is able to measure the diffusion of heat and therefore K values during its calibration cycles, providing frequent every 30 to 120 minutes K measurements over time. But the clinical utility of a continuous bedside brain water content measurement has been understudied. So we performed a retrospective observational cohort study of severe traumatic brain injury patients undergoing multimodality monitoring, including the QFlow 500 probe at a level 1 trauma center. We cleaned the data using values for which there was a stable thermal field. We verified the probe tip location using CT scans by 2 physicians. And we included 128 patients. They were aged 43 years. And they had overall 6,285 different K values for us to look at. The median was 29 K values per patient over a median monitoring period of 65 hours. Here's an example in Figure 2, right in the middle, of cerebral edema monitoring in clinical practice. What you see are the intracranial pressure, mean arterial pressure, perfusion or regional cerebral blood flow, the K value, the PPA, or a measure of thermal field pulsatility and distortion, the brain temperature and the delta temperature, and the PRX, an autoregulatory index. What you notice in the red dashed line is that the K value increases over time over the course of this 12-hour segment. It increases as the intracranial pressure elevates, and then the dashed line, the first dashed line, indicates hypertonic saline administration, after which the K value is reduced. A subsequent hyperosmotic agent is used, but the intracranial pressure is refractory at that point, and you can see the K value continue to rise despite appropriate therapy, finally culminating in the use of pentobarbital. Nonetheless, you can see cerebral edema continues, which fits with this refractory intracranial pressure crisis. And so this is an example of how the thermal conductivity provides sort of that continuous measure of what you might expect from repeated CAT scans. Across all of our patients, there was a bimodal peak in the histogram of the K values. There was a distinct peak at 5.1, which is a K value that falls within the range of 4.8 to 6, 4.8 being approximately 68 to 70% brain water, and 6 being approximately 100% brain water. 56% of the values were between 5.1 and 5.65. We looked at 242 CAT scans. It was a median of 2 CAT scans per patient, and half of the probes were in white matter. And there was a shift in the location between CT scans in about 1 out of every 5 patients. But what we noticed is that half were in white matter, half were in gray matter. The K values that were recorded within 2 hours of that scan, we found that gray matter tended to have a higher K value, a median of 5.5, whereas the median K value from white matter was 5.1, and that was statistically significant. Our K values trended over time based on location and overall did show a consistent maximum K value about 59 hours from injury. The Figure 3 on the bottom shows the density plot of K values in white matter and in gray matter. And what you can see over time here in red is the probes placed in the white matter, and in black the probes placed in gray matter, and the K value normalized displayed over time. And in aggregate, what you can see is this very clear rise slowly over the first 2.5 to 3 days, followed by a plateau. And that goes along with our clinical experience, right, of a peak swelling period of 3 to 5 days. So what we conclude here is that continuous bedside monitoring may provide some important information about the development of cerebral edema in real time, with a peak at about 2.5 days from injury. There's a relative difference that we found in brain water content related to probe location within tissue, and that's critical to interpret both edema and blood flow monitoring. So we are able to conclude that K values can be measured acutely after traumatic brain injury, and that values surrounding 5.1 and 5.65 may reflect different locations that serve to provide a benchmark or baseline by which continuous monitoring can be performed over time. I hope you enjoyed this poster. Please don't hesitate to reach out if you have any further questions to myself or any one of the co-authors, and I appreciate your time. Thank you.